for most healthcare professionals and most healthcare organizations, they came into the space because they wanted to help people. And that is, you see that theme throughout people's mission. And when you ask people, why did you become a nurse and why did you become a doctor?
Mhm.
And so when you don't address health inequities, there's such a large portion of the population that you're not reaching. So just as a healthcare organization and as a healthcare practitioner, just from that personal mission statement, I think it's important.
You're listening to the Health Disparities podcast from Movement is Life. I'm Christin Zollicoffer, a member of the steering committee at Movement is Life, and I'm also the Chief Belonging and Equity Officer at Lifespan, which is a partner and academic medical center with the Warren Alpert School of Medicine at Brown University. We've spent the past couple of months focused on the question, what role and responsibility do hospitals and health systems have in addressing the rampant healthcare disparities in our nation? If you've missed any of our recent episodes, I'd encourage you to go back and listen to the conversations we've had with phenomenal guests from the Commonwealth Fund, the Joint Commission, U.S. News and World Report, and the Massachusetts Health and Hospital Foundation. To round out our series, we're going to talk about the real practicalities of doing this work of changing systems and changing organizational culture, because that's what's needed to happen in order to truly put health equity at the center of operations. Today, we're joined by Linda Howard, a consultant with many years of experience in healthcare compliance, DEI, diversity, equity, and inclusion, and health equity. Linda, welcome to the Health Disparities podcast. Thank you so much for being here. Really quickly, have a shameless plug before we dive in. I know, this is what we always do. We have a plug for our Movement is Life's annual summit. This year's theme is Health Equity Solutions from Healthcare Leaders. The conference takes place in Atlanta from November 14th through the 15th. It's an incredible event, bringing together stakeholders from different and diverse backgrounds to discussing health equity challenges and equitable and actionable solutions. It is a very fantastic and engaging interactive summit. We hope you can join us. Visit our website, movementislifecommunity.org, for all the details. Okay, Linda, you ready to jump in?
I'm ready to jump in.
Let's do it.
Thank
So
you
why
for
don't we
having me.
start off by tell us a little bit about your background. How did you become involved in healthcare operations and compliance? And what led you to focus on health equity?
Okay, so way back, I was an attorney, and then I moved to the healthcare space about 20 years ago. I started out in operations and then in healthcare compliance. And I later started moving into diversity, equity, and inclusion just because there was such a great need for it. And also, it was so much of my lived experiences of navigating law firms, corporate America, working in healthcare, and just witnessing firsthand some of the things related to inequities. And I started out focusing on DEI generally, but I started to narrow my focus. And one of the areas that I've narrowed my focus to is health equity, and it's just such a natural transition for me because of my years of experience in healthcare and understanding how healthcare systems operate. I've worked as a interim chief compliance officer for hospital systems. I've also worked as an interim chief compliance officer for patient assistance programs. I've worked on the health plan side, working with managed care organizations, accountable care organizations. So I've had the benefit of working in a number of different healthcare systems, and I've also just had the lived experience of really dealing with the impact of health inequities. I am one of seven children. Five of my siblings have passed.
Mm.
Uh, four of them, I will say, to premature deaths that I directly tie to health disparities and health inequities. I also experienced that at a very young age with my father, who had end-stage renal failure. So when I, take all of my experience in the healthcare space and just my life, it just has created this great passion for this work around health equity.
So I can tell you, Dr. Howard, do you prefer Dr. Howard or do you prefer Linda?
Linda's good.
Okay, excellent. So Linda, when you were originally sharing your history, it's rare to have a DEI practitioner come into the space having so much experience on the administrative side from compliance and on the payer side, right? That's truly seeing DEI and health inequity from a different perspective because you're looking at the aggregated data.
Yes.
Then when you couple it with personal loss and personal experience and being able to see that firsthand, let me first say, my condolences. That is such a strong experience to relive, so close and proximate to your own person, where you feel it, you see it, and you can say, okay, this is not just large data. This is
Right.
not just aggregated experience. No, this is very personal. This is one-on-one. So that's pretty impactful, being able to come in and bring all of that experience together to DEI and health equity. When you think about systems level change that has a cost, what's in it for health systems to make change happen?
Well, I think that there's a number of things. One, you can look at it as the right thing, the good thing, from the moral side. For most healthcare professionals and most healthcare organizations, they came into the space because they wanted to help people. And that is, you see that theme throughout people's mission. And when you ask people, why did you become a nurse and why did you become a doctor? And so when you don't address health inequities, there's such a large portion of the population that you're not reaching. So just as a healthcare organization and as a healthcare practitioner, just from that personal mission statement, I think it's important. Also, there's looking at the impact that it has on communities, and I shared a little bit about my story in terms of my family, but it's not just the patient that it impacts, but it does have an impact on families, and it does have that ripple effect, and it has an impact on communities because individuals and families make up communities. It has an impact on the productivity of the community. So from that perspective, it's real. Now, when you say for healthcare organizations, like what's in it for me, I talk to healthcare organizations and individuals looking at it from different perspectives. There is, I put on my compliance and my legal hat, and there are some serious compliance and legal consequences to not addressing health inequities. For example, I know that the OIG recently, in their compliance program guidance, had put a great focus on quality of care as a compliance issue. And a lot of people don't make that connection between quality of care, compliance, and that can lead to organizations having violations of the False Claims Act, which is serious penalties associated with that. So when you look at issues of not being able to deliver culturally competent care to a patient population that you're billing Medicaid and Medicare for, there's some serious consequences there. You also have CMS, who is really starting to put a great focus on health inequities and taking that into consideration, and as it's doing its star ratings for organizations. The Joint Commission is also now has an accreditation related to health and health equity. So there's just the side of it from a regulatory, from a legal standpoint. You've had healthcare organizations that have had lawsuits filed against them for health inequity issues. One case was related to the use of artificial intelligence um, in the healthcare space, and using algorithms that made determinations that populations, and particularly African American populations, didn't have the level of sickness to put them into certain programs, because what they did was they associated spending on healthcare with the degree of the illness. And so it was a
Mhm.
full formula. And as a result, you had people of color who were not placed in needed programs, where other groups of people were placed into those programs. And that resulted in lawsuits. So there's a lot of implications that can happen when there is not a focus. And then I would just kind of wrap that up with just looking at, some of the other issues, just like just patient outcomes. There's just more adherence to treatment programs when there's culturally competent care, less readmissions, less claims against hospitals for discrimination. So
Mhm.
there's a host. I could probably take up this whole session just talking about all the benefits that healthcare organizations and healthcare professionals gain from focusing on health equity.
Absolutely. And you've mentioned a few of those needed systems to motivate hospitals. That is, NCQA, looking at those quality measures. It is CMMS. It is also Joint Commission. And quite frankly, without those accrediting and regulatory bodies, coming in and mandating the requirement to set the infrastructure, whether it's data collection, data standardization, it does make a huge difference. Without that push, I don't believe many health systems would have even embarked upon this journey.
Right.
So I really appreciate that, and those are real costs that are associated, and they do have a true downstream impact to creating a system not only that's beneficial for patients and communities, but also for the health system in itself. We know that there's such thin margins, profit margins in healthcare overall. When you think of specific examples of healthcare organizations that successfully prioritize health equity and the impact it's had, a few come to mind. Who comes to your mind?
Um, I haven't worked with them personally, but I have read, studies, and Kaiser is one of them. I know Kaiser has did a big focus on health equity and cultural competency, and they've done some studies and showing that once they started to implement these programs, education focused on cultural competency, there was improvement in patient
Mhm.
outcomes. Um, there was also reductions in readmissions. So I know, if someone is interested, they should kind of look at that Kaiser study. And I know
Mhm.
that is one organization that comes to mind for me.
Kaiser is very strong. I would actually put Rush up in that upper echelon as well. They move within a mission to eliminate human suffering. So I would advocate. You're right. Kaiser is doing strong work. Christiana Health System is doing well, as well as Rush. And when we think of some of the major barriers that hospitals face, especially in this political climate, when it's easier to back down or stay silent.
Yeah.
What do you think of when you put your compliance hat on, when you put your legal hat on, when you're looking at managing MCOs and ACOs? What are some of the major barriers that hospitals face when they're trying to implement some health equity initiatives?
There are numbers of them. One is just some of it is just resistance. Is that you have your healthcare practitioners that don't want to go through the education. They don't that there hasn't been enough of a discussion around kind of the need for it,
Mm-hmm.
and so there's some resistance there. It also requires for there to be infrastructure changes, which cost. And so there's those cost consideration. there's a need to also just do assessments, look at policies and procedures, and redo policies and procedures, implement new policies and procedures in order to do that. And then there's when I put on that legal and compliance hat, and as I said, I have the benefit of being on both sides of to have the discussion around patient-centered care, and being on that side of being with family members who were the patients and understanding the importance of patient-centered care. But I've also been on the side of working for these health systems, having to navigate a very complex regulatory environment. And so there has to be a balance when putting in place health equity programs, making sure that you're not violating any regulatory or laws. Like for instance, the anti-kickback statute
Mhm.
prohibits giving anything of value in order to influence a patient to use services that are going to be reimbursed by Medicaid or Medicare. And so if a hospital says, okay, or a practitioner say, okay, I want to give patients incentives, even health plan incentives to do certain things, they have to be able to do that in a way where it's not viewed as a violation of the anti-kickback statute. You have HIPAA considerations. If they want to share data with partners, they have to do that in a HIPAA compliant manner. It may be, being sharing aggregate data where the information is de-identified. It may mean getting permission from the patients to share that data. It may mean putting business associate agreements in place, making sure that the individuals that they're sharing data with can protect that data. So all of those things, like when you start to think about implementing programs, I always advise. I always advise organizations that compliance should be involved in that process, and sometimes it's necessary to bring legal involved. But initiatives need to be looked at from a compliance perspective. It doesn't mean that they can't be done. It just means that they need to be done in a compliant fashion, and that needs to come into consideration as well.
Well, as a fellow DEI practitioner, I would add to those barriers the lack of education and
Yeah.
consistency, right? So when you're thinking of executive teams, and you put on your DEI hat, taking off your compliance hat, have you experienced the lack of education and understanding of what health equity is? Many folks, when they think about health equity, their filters are Black and Brown folks, right? Um,
Absolutely. As a consultant, I go into a lot of organizations. Sometimes they're long-term engagements, like an interim chief compliance officer, where I may be in there 9 months, 1 year. Sometimes they're shorter engagements. But I did have one client where there was discussion around health equity, and there was a lot of resistance. And the conversation was, do we have to do it? Is there a regulatory requirement? And then this discussion around health equity just spent off into a whole nother discussion around other DEI issues like hiring and procurement. And then they wanted to set up a whole committee to address. So, it spent off, and it took on a whole life of its own
mhm.
that really moved it away from the health equity discussion. And at the time that I left the organization, I was working with them in a compliance capacity. They were very slow moving to put any kind of initiatives in place related to health equity, because it just took on its own life, and then they started thinking about, from a operational standpoint, how much is it going to cost us to operationalize this? Because sometimes when you're on the perspective of wanting to do the right thing, you can think about all the things that need to be done, but
Mhm.
not looking at what does it take from an operational standpoint, like just collecting data. What changes have to be made in the system, what things have to happen in, epic, which is a lot of what a lot of health systems use. Then what kind of training has to take place in
Mm-hmm.
order to for people to understand what they need to do. Then you get the resistance because now you've added another step. And from those who's entering that data, providers who have to fill out medical records, they start to balk at, wait a minute, you've added another step. We're trying to be,
Mm-hmm.
we're trying to have efficiency here and you're adding things. And so the discussion is, you know, do we need it? Do we need to do this? Do we have to do this? Because let me tell you what, this is a heavy lift for us to make this change, for us to start even collecting this data. So yeah, those are real barriers, and I've been in those discussions with organizations when they've started to set when they considered whether we should do this. And cost becomes a real factor, and also the education of the need for it from a community standpoint, and also the need understanding that this is where we're going. This is going to start to be more of a focus from CMS for joint commission, for different accreditations. The OIG is going to start to focus on it more. So them understanding that they need to get ahead of it, because this is where it's going, and I don't think we're going to stop this trend.
I agree with you. And even on the payer side, they're telling us that these changes are on deck. So there are incentives that are tied to financial incentives. There's a
Absolutely.
lot of reasons why this work is supposed to be done. I always think that there's education to dismantle some of the thought processes and stereotypes for whom health equity benefits. There's a lot of filters folks go through, but there's a lot of small steps that need to lead to building an infrastructure towards big change. And a lot of this is about culture change. I've
It is.
experienced that personally, when we're looking, from moving on the DEI maturity scale from being a check the box performative organization to being someone who embeds, or a health system that embeds it in the policies and work to then have transformation. Talk to me about how you've impacted complete culture change within a healthcare system so that health equity is front and center in everything that they do.
Well, a lot of it, as you said, is around education, and I think that education starts with leadership,
Mm-hmm.
um, because it needs to be incorporated into mission statements. It also needs to be incorporated into budgets. I tend to be very direct in my speaking, so a lot of times, the question is, have you put your money where your mouth is? Yeah,
Mm-hmm.
that's a nice public statement you made, but how is that reflected in the budget? Because you have to allocate resources. And when people start seeing resources being allocated towards things, then they start to take it more seriously. Um, and also having someone who has responsibility, where the buck stops. That there's somebody who is taking ownership of health equity, and that person is at a high enough level in the organization, that they can actually impact change. When you have your health equity officer, 5 levels down, they're not going to, they don't impact change the same way. Um, so I talk to organizations about, being able to put this into, the mission and the plan and the budget, and then to start to look at how you can begin to incorporate education throughout the organization, and being able to give real stories, because I think the real stories are important. When people are just looking at data, it's a little bit different than when they are really seeing how they work in impacts individuals, families, communities, and society.
You are so right. And when you think about budget, most folks think about budget in the only like FTEs or labor, right? Do you have a DEI team? Do you even have a chief health equity officer? Or are you asking folks to donate their time,
Right.
right? When they have a full-time capacity on one side to take on, a hobby in that sense of health equity? Or do you have dedicated resources, and those dedicated resources in the budget, they're not they're with team, they're resources, there's excuse me, research, there's clinical outcomes, there's interpreter services, there's so many different places for health equity to reside. And are you funding all of those? So completely agree with you there. It does take a lot of change. That's why we see a lot of folks who are looking to, secure funds and grants to support the work, because a lot of times the money just isn't in the health system to be able to dedicate to move it forward. When you think about where health equity is going, where do you see the trends?
I definitely, as I mentioned earlier, I see the trend that health systems are going to have to pay attention. And I think that they will pay attention because there are going to be regulatory requirements, and it's going to be too costly not to pay attention. And when you start tying the care that is not delivered in a culturally competent fashion to quality, and quality being tied to False Claims Act, because when you're billing for a service that you really haven't delivered, and if you haven't delivered it in a culturally competent fashion, then you haven't delivered it. When you have patients that come in and they are not adhering to a treatment plan, or you're giving them a treatment plan that they don't understand, like when you start getting into that health literacy thing.
Mm-hmm.
So a treatment plan that is misunderstood can be worse than no treatment plan at all. And so, I think the government is really starting to look at, the impact of this and saying, okay, what are we paying for? We're paying organizations to deliver competent care. And if they are not, and if they are turning a blind eye to it, then it's not competent. And when I look at it from that perspective, from the legal perspective, from the compliance perspective, and I think that that is going to really, really have an impact. And I also think that um, outside organizations, community organizations play a really big role. And
Mm-hmm.
the more that health systems can start to partner with those organizations, the better it will be. And I do think that you're starting to see organizations partner with, health systems partner with community organizations in order to have an impact.
I agree. You see that more and more today, and it's very much needed to really touch all parts of the community, right? Different touch points. There are some benefits to FQHCs. There's some benefits to clinics, small clinics, as well as health systems to be in partnership. I'm going to wrap up with one last question, because our listeners represent all levels of healthcare professionals, right? Policymakers, folks who are a part of associations. But if you could give one piece of advice to a healthcare professional who says, wow, health equity just feels like this mountain that I can't scale, what would be one thing that they can do to start addressing health equity within their organizations?
Well, one of the things is that I think people need to understand where they are. And so being able to look at their patient population and saying, and then looking at their provider composition and saying, do it, is there a match here? And oftentimes there's not. I mentioned that I worked on the payer side, and on
Mm-hmm.
the payer side, you develop provider networks. And and one of the requirements, like when you're working for a government program, is that you have an adequate provider network. And adequate is usually looked at as geographic. Like, do you have enough providers within a certain mileage to serve the population?
Mm-hmm.
I take it a step further and say, what's the composition of that provider network, and does that provider network reflect the population that you serve? So I think that one is just kind of taking an assessment of where you are. From an individual standpoint, I think individuals can begin to educate themselves. There are a lot of courses that individuals can take at an individual level, and then also start to get involved in advocacy work. Looking at organizations that they maybe can partner with in order to advocate for certain things. And so from an individual perspective, it's, yes, it can be big, but you take a first step and say, okay, I'm going to start with me and say, okay, what is it that I can do to expand my knowledge base, and who can I partner with in order to be able to get better outcomes?
Excellent. And thank you. Those are all fantastic insights for folks to start their work today. I'd like to thank you, Linda Howard, for sharing these incredible insights today to round out our podcast series on the role of hospitals and health systems in addressing health disparities. Linda, thanks so much for being with us. That brings us to the end of another episode of the Health Disparities podcast from Movement is Life. Once again, we'd love to see you, Linda, in person, and our listeners and viewers at our upcoming annual summit. Registration is open. We will be in Atlanta, Georgia from November 14th through the 15th at the Whitley Hotel in the Buckhead area of Atlanta, Georgia. Please go to our website to find more information and to register. MovementIsLifeCommunity.org. I'm Christin Zollicoffer. Until next time, be safe and be well. Thank you, Linda.
Okay, thank you.